an associate professor and researcher with broad experience in prevention across multiple areas. She has been enormously effective in her role as co-chair. The other co-chair will be reporting. Susan's last name? Okay. Susan McKee from APS, and she is the director of the Crossroads program. So let's just get going so we can stay back on a schedule. Thank you very much, Teresa.
I think we'll be the last ones to say good morning. The end of our morning. I wanted to thank Tim for his talk. Had I known he was going to mention it, I would have brought my 1987 Halloween photo of my sister and I as your brain and your brain on drugs. I do have that. Thank you everybody for coming today. We heard this morning about some of the data, some of the initiatives that are out there, and the piece that I'm going to be focusing on along with my co-chair Susan McKee is prevention. And we're the co-chairs of the Prevention Implementation Team. And we have along with us, I know everybody has acknowledged the work of Marcia and Bill and Harris, and I also want to mention Tracy McDaniel, who couldn't be here today because of a family emergency, but they've been instrumental in us being able to logistically get our work done this year. And then I'd like to ask if there are other members of the Prevention Implementation Team here in the room, if you wouldn't mind just standing up. So people could see who you are. We do work closely together in between these meetings to try to get work done, and we will be here during the breaks for anybody who wants to talk about any of the issues that we're bringing up today. So thank you. We had established at the first summit the 4 pillars, and all of these pillars are really meant to prevent overdose from opioids in their own way. Ours as and so when it said prevention, I was thinking we're not just prevention because all of these are prevention, but we're really primary prevention where we're working upstream to try to prevent the abuse and drug addiction in the first place. So this is working well upstream of some of the things you've heard about the treatments that are available and what's happening in the brain after substance abuse. We're looking at preventing that in the first place. So the goals that came out of that first summit that we are trying to strive toward achieving in the last year and a half, we're looking at developing a prevention plan for the county, for Bernalillo County, and a framework to work in. We're looking at expanding access to drug counseling and prevention in the school system for our school students here at APS. Looking at supporting early childhood programs, including home visiting programs. Working toward finding venues for disposal of pharmaceuticals so that they're specifically controlled substances, so that they're not being diverted. Looking at promoting evidence-based, and I know Dr. Roth mentioned evidence-based interventions. We're also looking at evidence-based prevention interventions as well as treatment interventions. And specifically here, we talked about looking for some evidence-based alternatives to opioid treatment, and then looking at reducing the supply of prescription opioids in the community, both through having a prescription monitoring program and through having prescribing guidelines established. So today I really want to talk about what's the progress that we've made in the past year and a half, and then how do we need to move forward? What are our next steps? And then we'll talk a little bit and ask for your help on some of the challenges at the end. So with looking at having a strategic plan or integrated plan for prevention for the county, we started out by developing an initial inventory of what are the prevention activities that are going on. And so we've established that initial inventory. And then recently, with some capacity building OSAP funding here in Bernalillo County, the Office of Substance Abuse Prevention funding in Bernalillo County, they're working on a community-wide focus with a capacity building grant to conduct a needs assessment and develop a strategic plan in the county. Now, the focus of that is broader than what we were originally talking about in our committee, which was looking at opioid use, but opioid use is included in that plan. And so we're going to be working closely with the county as they're conducting their needs assessment and building the strategic plan. Instead of doing dual efforts side by side, we'll have one plan that's coming out of that effort. And there are also other prevention activities that are going on in the county. And as I'm talking here today, you know, we've been on this prevention team, but as Marcia was talking about earlier with Collective Impact, we aren't going out and doing all of this work. Each of us is doing our own components of it, and some of the pieces are being conducted by people who aren't part of our team, but they're things that we know that are changes and activities that are going on in the county that we want to recognize as part of the efforts that are out there. And so there are other prevention efforts. We've got about $773,000 that are from alcohol tax monies that go into prevention efforts in the county. And those could include school talks, the tavern taxi program where they drive people drunks home so that they won't be driving on the street, and media campaigns that are out there. So those efforts are going on as well. So what do we want to do as we move forward? One of the things we've really been thinking about is instead of everybody doing these things separately, let's try to get on the same page. And so really looking at having a coordinated and comprehensive program for primary prevention in the county. Focusing on evidence-based strategies. A lot of times there are things that are nice to do, but we want to make sure that the things we're putting our money into are things that have evidence behind them, or as a researcher, to do the research to find the evidence for the things that we want to do. And then also looking for complementary funding or programming. For instance, the OSAP funding is focused on alcohol use and on prescription opioids, but as we've heard this morning, we also have a heroin issue. And so we might want to find complementary funding and programming to fill that gap to make sure those things are addressed as well. One of the evidence-based programs that's very promising and exists here in full force in New Mexico, in Bernalillo County in particular, is home visiting. We currently have 8 different home visiting programs. It's evidence-based for a lot of things, including academic performance, substance abuse, criminal activity. And so looking at ways, you know, people think of these as disconnected. This is so far earlier from when people try their first substances, well, not in the case of neonatal abstinence syndrome, not. But for the majority of kids, this is really trying to get at them before they've experienced adverse childhood events that could lead to these later negative behaviors and outcomes for their lives. The 8 programs here in Bernalillo County are meeting regularly and trying to improve systems strategies in order to better serve the community here. Things that they're looking at doing are having a centralized intake because all of them have different criteria. Some of the programs, it's only for first-time mothers. Some of them have income eligibility. And so it's a hard thing to navigate, to know which programs would be right. And so trying to find a centralized intake and establish that is one of their goals. And also looking at marketing. Right now they have 8 programs and only one of them has all of their slots filled. And so why aren't people participating in the programs that are out there? And what can we do to encourage that and to make it work? So the next steps moving forward for them are establishing this location for the intake, and they're working on now having the New Mexico Child Care Resource and Referral Center, which already exists, adding this on instead of developing something new, having this become part of that program. They're also looking at messaging. The Thornburg Foundation has generously donated some money to conduct focus groups to find out, for the people who are participating in programming, why are they participating? And then for the people who aren't, why aren't they? And what are the things that we can do to try to motivate those people to be part of the programming? And then securing funding for long-term sustainability. Dr. Roth talked about that, and I'm sure other speakers today will. But looking at potential for Medicaid coverage for home visitation programs and other sources of funding, including state funding, that would be able to expand that programming. And this is just informational for any of you who are interested in looking at that, how early childhood adverse events affect long-term outcomes. There's a book that's been written. I get no royalties or anything from this, but there's a book, A Path Appears, and they've created a documentary movie that's going to be screened at the Chemo Theater in a couple weeks, on the 28th, for people who are interested. They're also going to be screening it for the legislature and for the faith-based community to build support for early childhood efforts. Another issue that we had as one of our tasks that we've worked on is the disposal of pharmaceuticals. Currently, there are 9 locations in Bernalillo County. These are APD substation offices, which are the red points on the map. And so those are locations where people can dispose of pharmaceutical controlled substances that they haven't used or have left over after, say, an orthopedic injury or that kind of thing. They're, up until now, the only place that you were allowed to dispose of controlled substances has been through a law enforcement agency. In September, the U.S. Attorney General Eric Holder did put out information saying that there's a new DEA regulation that will allow other organizations, will authorize them to be able to collect opioids, and those include pharmacies, nursing homes, hospitals, but right now in New Mexico, there's no way to operationalize that, and so that may be something that can happen in the future here. We talked about alternatives to opioids. So this is looking at alternative forms of treatment that people can have. There is some evidence out there that different physical medicine treatments can help reduce pain without needing to prescribe opioids. And those are things like acupuncture or chiropractic care or occupational therapy. They can't replace opioid use overall, but for some patients, this might be the best and most appropriate treatment. And so looking at ways to expand that in New Mexico. Moving forward, the Chiropractic Association in the upcoming legislative session will be proposing 2 bills. One of them to look for having Medicaid coverage that would cover chiropractic care, and the other looking at having chiropractic care covered the same as a primary care visit. So if you have a copay that's $25 for primary care and $50 for specialty care, currently it's considered specialty care, and being able to move that into primary care. And so if you're interested, those 2 bills will be moving forward in this legislature. And Michael Pridham, who stood up earlier in the back, is working on that effort. The prescription monitoring program, this is one of those evidence-based programs for primary prevention. And the idea behind it is really that you're trying to reduce the amount of prescription opioids that are in the community, that are available for diversion, for abuse. And so looking at how can we kind of scale back the amount of drugs that are out there in the system or in our communities. So a few years ago, the Prescription Drug Misuse and Overdose Prevention and Pain Management Advisory Council, hereafter known as the task force, started meeting to try to figure out what can be done systematically, system-wide, to really affect change, looking at population health. So this isn't a matter of each doctor deciding what they're going to do differently. This is a matter of bringing together all the boards of all the prescribers in New Mexico, bringing together the Board of Pharmacy, who runs the prescription monitoring program, bringing together addicts and people who've had addicts in their family, people who have had severe chronic pain and needed to have that treated, and people who work at the pain center. And so it's bringing all of these people together to talk about what can be done systematically, system-wide, to make a difference. And so each year they come out with recommendations of what those changes should be. One of the big changes that's happened in the last few years has been within the prescription monitoring program at the Board of Pharmacy. And they ended up making it a requirement that anybody who wants to prescribe opioids, controlled substance opioids in New Mexico has to register with the monitoring system. What this then allows physicians to do as registrant is to go in and access information on patients who have obtained prescription opioids. Well, other controlled substances as well, but so they can go in and see what are people being prescribed, and if Teresa Cruz comes into the doctor and asks for opioids for back pain, they can look in there and see she got them 2 days ago or a week ago or 5 times in the last month, and be able to be more informed when they're making decisions on whether or not somebody should get a prescription. What they found is now about 87% of prescribers in New Mexico are registered in the system, controlled substance prescribers, and they're investigating what's happened. Is there some kind of loophole or what's happened with those other 13% to try to get everybody in there. And about half now of prescribers are using the prescription monitoring program before they prescribe to patients. So that's a big improvement over what was happening before, mostly because it was a difficult system to access. It wasn't real time, and so physicians, and it wasn't required that they be a registrant, and so physicians didn't have much incentive to contact it if they have a patient in their ER that they're trying to process and get out if they wouldn't be able to get the information back quickly. Now, because it's real time, it's much more user-friendly, and the Board of Pharmacy has worked really hard to get people registered, trained, and able to use it. And this is one of the results, is the MMEs are morphine equivalents, so that's trying to have a standardized measure for all opioids that go out there. And we've seen a turn in the amount of opioids that are being prescribed. So the top line is Bernalillo County, the bottom line is the state. And so the line's converging there on the end that the county has really come down in the amount of morphine equivalents. That doesn't mean the number of prescriptions, because there was a worry that doctors would stop prescribing. But what they've actually seen is a slight uptick in the number of prescriptions going out, but a downturn in the amount. And so that means they're either getting a lower dosage or a lower duration of the drug, as opposed to not getting any drug at all. The other thing that we've seen is, and again, we talked about no one thing, and Harris was mentioning that it's a lot of different things that are taking effect here, but we do see, parallel to the downturn in prescribing, a downturn in the deaths that are happening. And it's not the factor, but I believe it's one of the factors that's contributing. There's just fewer narcotic opioids that are available in our community. So what are they doing moving forward? Thankfully, our Board of Pharmacy was a recipient of a recent grant award from the Bureau of Justice that's going to allow them to expand their activities. So they're going to be enhancing their unsolicited reports. So if being able to signal if a patient is somebody that needs to be concerned about, so that physicians will be alerted or pharmacies will be alerted. Increasing dispensing reporting to daily. So currently the pharmacies are required to provide data on prescriptions that were filled on a weekly basis, and they're going to be going to a daily basis with that, and hopefully by mid-year that'll be done. They're also looking at separating out UNM residents. Right now they're all just clumped together, and so they'll each have their individual number and way to track in the system to look at the prescribing practices. And they're going to be developing a practitioner report that will go out to the prescribers so that they see where they fit within their peers in their specialty in their prescribing practices, to inform them so that they can have an idea of where they fall on the bell curve of prescribers. And another, in our state especially, thing that I think is wonderful is they're going to be looking at ways to link up and add in data from the VA and data from IHS, which are two obviously big players in prescribing in our state. The last issue that we had on our list and that I've saved for last here is the school-based prevention. And For those of you who were at our update meeting last June, this is the exact same slide I presented there, unfortunately. We were really hoping that we would be making some progress on being able to get better primary prevention in the school system. Currently, APS has 7 Crossroads counselors, substance abuse counselors, for 13 high schools, and I think it's 25 or 26 middle schools, which don't have any coverage at all. And part of the problem with this is if these people are devoted to crisis intervention, they're not going to be able to work on the prevention that are going to keep people from being there in the first place. They're not going to be able to spend the time identifying and working with high-risk youth to prevent them from abusing in the first place. And so this area has just been intransigent and is the area that we're going to ask, I think, for your help in trying to work on figuring out how to resolve this. And to talk to you about, so yeah, here's our progress slide. So we haven't gotten very far with this one. The others all seem to be moving, and it's been a very positive year for those. But this one, Susan McKee, who works at APS, is going to talk to you about what maybe we could do there, and then to solicit some of your ideas about this. Thank you.
So my name is Susan McKee, and currently I'm at the district level as the manager for several of the behavioral health provider programs within APS, and of those, Crossroads is one of them. The Crossroads program has been in existence in APS for 18 years. On soft money. And that's been sort of my plea from the beginning. From the very first summit where I got the opportunity, and thanks to Bill and Harris, they asked me if I wanted to be on the panel, that my plea is this, as I'm looking at it. So it's existed all this time. I've been a counselor. I was a counselor in the schools at all the different levels for 15 years, and then became a Crossroads counselor myself, and I thought, you know what, this is like a really well-kept secret in APS. Why do we keep going on grant money, which then what that does, of course, soft money, grant money, some years, because the grant's big, you have 13 counselors. Other years, like now, where the Crossroads counselors are being paid this year on Medicaid carryover funds. So it expands, it contracts. In the ideal, and for it to remain an evidence-based program, we need absolutely one counselor handling one school. I think everybody's well aware of the problems that we have among our youth with substance abuse. And the opioid and heroin problem has come in a big way. It's receded a little bit, but I'm being assured by some of the Crossroads counselors that it's coming back in kind of a new way, new packaging. So if you ever think that organized crime has nothing to do with marketing to the school-age kids, think again. I think that the marketing that went on in the Northeast Heights for heroin completely changed. That was marketing by a cartel, and that completely changed how now we view heroin. And like Dr. Condon says, back in the day, it looked very different when it first started. So at any rate, I'm going along. I become a Crossroads counselor. I know I'm doing good work. I know I'm reaching out to families and getting them involved. I know I'm doing good education and so forth. And then, like I said, I just thought, this is a well-kept secret. Why, if a program has existed for 18 years, so obviously something's happening, then why is it not permanently funded. And at this point, and I have to thank Commissioner Hart-Stebbins for this, because I got to be on that first panel, then it's kind of opened the door for me to have conversations about this program with people at APS, with people at the city, with people at the county level. However, and I want to stand here next year and say, I have heard the words, we have the money for, the permanent funding for you. And I can tell you all that we're at least, at the very minimum, I want to start with the 13. Really, age of first use in New Mexico for kids is age 11 or 12 at this point. And so we have to, in a way, my being on the prevention team is a bit of a misnomer. And they tried to kick me off because they said, your counselors are doing intervention. They're not on the prevention end of things. And that's where I want to get everybody, is to where they can do that. So by being employed, one at a high school, then they can deliver an evidence-based program in its entirety. All of the APS principals love them because they're on the discipline matrix. So if a student gets caught in possession or using or any of those things, the way that goes is they get sent to the principal's office, the principal calls the parents in, and then they're offered an evening psychoeducational program in lieu of the full suspension that they might have gotten. They'll get the mandatory 3 days, but then if they sign up for it's called the Parent Involvement Program, or PIP, then they don't get the extended suspension, which none of us want. I mean, really, what are they doing when they're out of school? So there's that aspect. The counselors get referrals that are mandatory. But the really beautiful part, though, of getting to be in a school, and for them, they're all experts in what they do. They know what they're looking for, early signs and things that we've been talking about that might be there. If they're at a school and part of the fabric of the school, they can see those things where other people look the other way or don't even know, really what they're looking for. So what they're able to do is, at that high school level, is see students individually. So they have voluntary students that are worried about themselves. They may be becoming an addict and they've become worried. They can safely go talk to a Crossroads counselor, and that doesn't get reported back to administration. Those counselors can assess, and if it becomes, if it's a larger problem, then obviously certain things need to happen, but they can work with the kids in the schools. The kids can go in and talk about if they're worried about a parent, if they're worried about an aunt or an uncle. And I know at one of the schools, the Crossroads counselor's been telling me that a lot of the kids she's dealing with are not coming to school because now we've moved into kids who are feeling like they need to stay home and take care of addicted parents, and the kids and so forth. So it's it's interesting how the cycle is going on, but they can make interventions. They do a program that's called the Preventive Education Series to all the ninth grade classes, all the ninth grade students at the health class level. So that's right now about the only prevention aspect that can exist, and that's because they are dealing with crises. I checked yesterday and was told that the average caseload for them is 90 to 100 students at their school. So with that, and also we all know this, if with someone who's a substance abuser, with a high school student, you have a certain window of opportunity to maybe make an intervention. If they're a substance abuser, it's a little window. So let's say a student has been up overnight doing heroin or opioids, and they think in the morning, you know, I think I'm going to go and talk to Ms. Medina or whoever, that Crossroads counselor at the school. I think I'm going to go find her. If she isn't there right then to intercept that, and they leave notes if what I'm trying to explain is if they're at another school and they can't get to it for another 1 or 2 days, the kid, usually when they go to find the kid, they've been long-term expelled by then. So I want to further the conversations. Positive things are happening where there's definitely an uptick in it being sort of globally known that we have this problem, because one of the new counselors' wife, who works at a hospital, said, you know, you just hired onto a program that's very iffy. And he said, yeah, I know that. So in reality, at the end of each year, there's that discussion. Will we be here next year? Will there still be 7 of us? Will there be this? Will the district take us and try to split us between 2 schools, which we know doesn't work? So in that process, you know, we lose a lot of really good counselors because they can't, for their life situations or whatever, deal with the ambiguity of, are we going to be here or are we not? So and I want to say that all of my counselors, one is missing, but all of my counselors, and I call them my kids now, are back here in the back of the room. Lisa Goldman is, would you guys stand? Lisa Goldman is at Del Norte High School. Debbie Medina is at Rio. Once a Raven, always a Raven, that's what she always says. Lisa Searle is at La Cueva, and then Jennifer Montano is at Valley, and Michael Verrilli is at Albuquerque High. So, and oh, whoops, and Samantha Ashby is at Manzano. I'm sorry, I couldn't see you, Samantha. Who signed your passes for, oh, I did, leave slips. So at any rate, I really want to see, if we're talking about collective impact, there is recognition, you know, from the county. There's recognition from the city, recognition within APS. Okay, within APS. Yeah, it's really a valid program. We need to do that. Who's gonna ante up is my thing, because have you talked to so-and-so or have you talked to this person? So there is a House bill, is my understanding. Senate bill that is going to include, does it say Crossroads on there? Do you know?
I haven't seen the legislation, I just know the intent, so certainly
Okay,
that information to you and what it looks like.
okay. All right, so I want that name on there. We've talked about changing it because there's another program called Crossroads for Women that's an excellent program, but it's existed for 18 years under APS Crossroads. So the collective impact, I feel like, is sort of putting a wedge under this rock and boom, trying to get it to roll on. So in this slide, I want you to know that, well, the Crossroads counselors are a door. They take the kids from early childhood, the early childhood visitation programs we're working on. They get those kids, they get those families, and they work with them. And then they go on, and are they going to end up in MDC, JDC, or are they going to become constructive members of our community and maybe reach out and help other people? So I want very much for us to be replete initially with the 13, and then I have bigger visions later. But at least have that so that we can make a dent, because even though we talk about evidence-based programs and what we are using now, we're as best we can at 7 people trying to make it evidence-based, trying to stick to the evidence-based, and luckily there is data that's collected at the district that we can kind of take a look at things. But what I want to do is bring it down to where this all starts, and that is with the kids and what they bring to school. In their backpacks is not just a notebook, pencils, and pen. They've got poverty. The counselors keep food in their offices so they can at least have something to eat and pay attention. There's poverty, there's developing addiction in themselves, there's a history of addiction in the family, there's hunger. So all those things, they're showing up at school every day, carrying those in. And I would like to see us, since this is a proven successful program, join with other initiatives in APS on truancy. Those are the same kids the Crossroads counselors deal with. These new initiatives we need to, at the APS level, definitely try for collective impact. And I'd like to get the principals, rather than saying, I need one at my school, to say, why don't we get one for all of you at all the schools? So at any rate, it's a very real thing, and a student, as you see kids walking to school or walking home, think about the fact that they might use tonight and not be here tomorrow. That's the real deal. And there are people in this room who have sons and daughters who that's happened to. And it's definitely an imperative that we need to keep going after. So I want to keep that ball rolling. If you have questions during the day, my guys will talk to you about what's going on in their area. And that's it. That's my time. Thank you.
Don't go anywhere, don't go anywhere. Thank you. Aren't they great, Teresa and Susan? Bill and I met Susan at Satellite, and within 5 minutes, I was very fond of her. And within another 5 minutes, I knew the Crossroads program was the bomb.
The bomb, I like that.
I said to Susan, I said, if you could get 2 counselors at each high school and 1 at each middle school, what could you do with the drug problem here? She goes, knock it out. So she's just full of energy and great. So we have some time for Q&A for Teresa and Susan. So if you'd like to go to the microphones on either side of the room and step up. We'd like to limit comments to about 2 minutes if you're going to give comments, and they're available for questions.
You know what? I want this program not to be a secret, but to be known by everyone, because it is a very valuable program. I've been in education for 44 years, and I have seen this program work. We always look for programs that are best practices. We have one, and we need to find ways to sustain that. And we, within our budget, always look for that funding. We are still being funded in New Mexico at 2009 level, and our revenue this next coming year doesn't look very good either because of our oil and gas prices. Of course, we're very happy about it, but that does reduce the amount of funding in our schools and for many of our programs. But I do ask for your help in helping us connect with you for resources and also human resources in terms of how we partner and collaborate together. This is a really important issue that we need to address. And in our public schools, we do have the audience, we do have the clients, we have students that need our help. And I would say that a minimum, it's not 13, but it's more like 26, if we're even gonna make a dent. Because I think we have students at the middle school as well as the high school that really need this program. So, once again, I would plead with you, if you have any way that we can partner with you, that we can work with you, look for resources so that we can continue this program. The best practices also include our early childhood programs, and we are very fortunate to be able to work with many of our early childhood providers, UNM, YDI, lots of programs. That is a very critical prevention program as well. I also want to mention the work that Patricia Rael is doing in really documenting the stories of many of our youth, and it's heartbreaking. You know, those stories need to be heard because we can make a difference if we work together. So again, thank you for being here, and if there's anything that we can do to partner with you, or if you have any ideas, please call me. I am on the APS website, and thank you again for being here.
Daryl.
Hi, good morning. My name is Daryl Smith. I work at the Health Sciences Center at UNM, and I don't have a question as much as I do a suggestion. I've been receiving a lot of emails lately about supposedly there's an open comment period right now for characteristics that we want in the next superintendent of Albuquerque Public Schools. There's also a couple public meetings coming up. That might be a really prime opportunity to encourage them to support programs such as this in their search for the next superintendent. So that's just something I thought I would recommend.
Raises is benchmarking and tools to monitor success. What have y'all done that we can see that shows your success so that we could use that as proof that this does work and people get behind you? So I'm looking to see if you're using any assessment tools like before, if there's anything like that. And maybe it's on that APS website that I haven't seen.
On the floor, it's called Student, Family, and Community Supports, which consists of several departments, counseling and nursing, and there's a parent university that's to bring parents in for parent engagement, family engagement. And at that level, we all need, at the district level, to be talking to each other. Everybody tends to get so busy and run in their own directions. The evidence-based is that each one of the counselors, they fill out a form that indicate, and they submit it electronically to the district, to the data department, that says what, it's a student number, there's never a name on there, a student number, what service they provided. Was it individual contact? Was it calling a family member? Was it a family session? And then they submit that to the district. So I've got a number of things. If anybody's interested, just email me. It's mckee_s@aps.edu. But I have some awesome graphs and things like that that show then, we do these studies, the effects of, let's say, the PIP, that Parent Involvement Program, the effects of that on overall truancy, and it's positive. It's a positive effect over a 2-year study. Do the interventions, are they reducing truancy, which they have? They've reduced like multiple referrals for student discipline, that goes down. We've had a hard time figuring out on GPA what the effects are on that. But there's a program called Project Success that we're trying, that everybody's been trained in. But that's just it. With the lack of funding, I can't get everybody trained in the same program, so we try to teach each other about it, but that's one of the evidence-based programs that for school-based substance abuse counseling. That's from upstate New York. And you know, I went to a training there, just briefly, I went to a training in New York for that program and found out that Alice King in the 80s brought them out and they trained all of the principals in this program. And it just astounds me. And then where did that go? We don't know.
Fortunately, Rio Grande High School is one of the schools that is blessed to have a school-based health clinic on campus. So work closely with the nurse The nurse will refer to me. We have a health and wellness team where the nurses participant, the counselors, and we refer a lot to the counselor that is on campus at the health-based, at the school health center. So we work together pretty closely because the kids that need to see me are also need to see her. So if a kid is high on campus, COT is high, the nurse will determine what the next step is. The nurse will then refer the student to me. I see them make an assessment. Is it okay? If they just continue to see me, do we need to have them see a counselor? And the great thing about having a school-based health center is the counselor is there all the time. If we refer out to community providers, they aren't always there when the student needs to see somebody. So having them there on campus, they can catch the kids right away. So working together with a mental health team and referring back and forth to each other with me and the nurses works well.
But I have two comments. One is that this program and the problems it's addressing seem to be not being dealt with as an integral part of the fabric of that environment. I don't have the statistics, but I can imagine a person coming into school from either taking drugs or from a house on drugs, where somebody else is on drugs. And I think there are a lot of those people. Question, what is that person's readiness for education? What is that person's educational performance going to be? Of the people who end up as truants, what percent come from that pool? And I know that truancy is presently one of the priorities or areas of interest. Of the people who drop out, what percent of those people come from that pool? I can't imagine that those figures aren't substantial. If part of the purpose of K through 12 education is to get our students to succeed, why is this program at the margin of the funding and administrative environment? I simply can't understand it. The school identifies routinely people who are handicapped in learning and invests in those people with early identification and the channeling of resources to help those people succeed. I can't see how this is different. These are young people who have a handicap and are at the short end of likelihood to succeed, not getting those kinds of resources except at the very margin. I see this as a problem that underlies so many things that are basic to education, is that why isn't this problem, why doesn't it have a chair at the center of the discussions and the planning as to how to make our school system better? I don't understand it. I'd love for somebody to explain it to me. We're now going to hear from our treatment implementation team. We'll have reports from Michael Robertson, Nita Cordova, and Harris Silver will also be talking. We've asked Miriam Kamarami to be a respondent. And so what I'll do is briefly introduce those people, and they'll take it forward from there. Dr. Michael Robertson, PhD, works for the city of Albuquerque. He manages the Division of Health and Human Services. His degree is in anthropology. It covers cross-cultural mental health, cultural, and the social service system. He's been in this field here in the Southwest for over 30 years, looking at mental health. He's had a wide variety of work experiences involving many organizations, including Albuquerque Healthcare for the Homeless, St. Martin's. He's worked in programs working with case management, behavioral health, Native American programs. So he's one of the co-chairs. Other co-chair is Anita Cordoba. Excuse me. Anita is native New Mexican. She's Director of Development, Planning, and Evaluation, Albuquerque Healthcare for the Homeless. She's been with AHCH for 7 years. She has a decade of experience working with community-based health and civil legal agencies, issues of domestic violence. She's worked with community corrections, so has extensive background in looking at trying to get implementation of treatment programs in the field, often in challenging environmental circumstances. Importantly, at Healthcare for the Homeless, she was involved in the design, implementation, and ongoing performance improvement of the Reentry Collaborative. And she can explain that, people being released and then getting from incarceration, getting into treatment with an incredibly strong record for outcome. In our implementation team, she chairs the MAT group, Medical Assisted Treatment Group, trying to get that moving forward. Miriam Kamarmi is an internist. She's board certified in internal medicine, addiction medicine. She was, among other things, here in New Mexico, she's been the medical director of the Addiction Treatment Hospital, Turquoise Lodge, the Department of Health. Did that for 5 years. She created the Medical Observation and Treatment Unit in collaboration with Bernalillo County. She's worked with Project ECHO for many years, started the Integrated Addictions and Psychiatry Tele-ECHO program beginning in 2006. I've participated in that from time to time. I think it's a very important program, and involving clinicians around addiction and behavioral health issues in hundreds of persons in many New Mexico communities. She's just got many credentials in this area. Beginning in December of 2012, she began full-time as Associate Director of Project ECHO. As Dr. Roth mentioned earlier this morning, that has been a incubation bed for innovation in better treatment, extended into situations that were not being adequately served. And I think by implication, Dr. Roth was implying that people working in those kinds of environments at the university should be of help in putting their brain power to work on some of our issues in terms of advancing the scope of addiction, into treatment into the addiction world. So very much looking to her for her response. So we'll begin with Mike. Is that where we're going to start? Yeah. Okay, so Mike Robertson, and then Anita, then Harrison, and then Miriam.
Thank you, Bill. Gee, we sound like we're in a coughing ward here. Well, good afternoon. Everybody made it through the morning, and thank you for sticking around this afternoon. I'm going to kick off this first piece talking about our treatment implementation team as part of the initiative that we've been talking about. This group was divided into a couple of different groups finally, and one of them that Anita Cordova is going to talk about would be the MAT piece of this. And thank you both for joining in with this, and Dr. Kamarmi for responding. I'd like to begin by pointing out a behavioral health study that was just completed by the University of New Mexico, funded by the City Council, to do a needs and a gaps analysis of behavioral health services in the Albuquerque area. An important point that came out of that was that there's 151,000 people that require behavioral health services. This was done based on 2013 data. 151,000 people in our large community that require behavioral health services. Of this, 98,000 are receiving them. That leaves a gap of 53,000 people who are receiving no behavioral health services in our community. We're not sure where they are. This is a statistical measure, so we know that they're there, that the system has not touched them very much. This group, our intervention team, really is here to sort of address these people, all of these people, with what we have or don't have in our community. And we looked at two broad areas, at least in the area that I'm dealing with, and not the medically assisted treatment piece, of looking at expanding treatment services and developing a comprehensive coordinated system. What would that look like if we're going to be talking about treatment interventions in our community? So we looked at a handful of recommendations that came up at our last report out in June. And here we are again to report, so what progress have we made? What's happened since then? So let me mention just a few of these important recommendations that have come out of that we're trying to address through this intervention team. To develop a comprehensive inventory and mapping of current treatment services and to determine gaps in capacity and levels of care, to create the basis of an effective coordinated system, and to develop a current, consistently updated database of services accessible to providers and the community, including eligibility criteria and program capacity. Two important things. Let me mention something right now in terms of what has progressed, where we have come from. Well, that UNM study that I just mentioned is an outgrowth of this. So we have come a ways in meeting this. We have a gaps analysis. We have some really fine data. In fact, any of you who have not seen that, it's put together by a number of people at UNM, headed by Dr. Carly Bonham and Dr. Sam Howarth, putting together a really fine piece of work. And you can find this on the UNM website if you just Google UNM CEPR. And I think that stands for, somebody help me here, Center for Education and Policy Research. Thank you so much. Yeah. You'll see that when you get the web page. It's on the left side. Just click on that and you'll be able to see the study. It's a preliminary study, came out in October, and it's giving us a good picture of where we are right now. And it has a really interesting feature on this, and it gets into the next piece of this, to develop a current, consistently updated database. Something that people, I've been in this field a long time, and a number of years, people always saying this, well, what's the situation? How many people do we have? What are their needs? Where are they? We don't have a consistent picture. And this has an interesting feature on it. It's an interactive feature. You can go on the website, and it has the clinical services, the providers of our community, broad Albuquerque community, that are mapped on a map of Albuquerque, broadly speaking area, and divided into the color-coded, red, green, and blue for mental health services, substance abuse services, and both. And you can go on and click any one of those pieces, any one of those dots, and there will be an individual provider agency or perhaps an individual provider themselves. The box will open up and it will give you information on where they're located, contact information, what's the criteria to get into the program, what kinds of insurance is required, and on and on. It's a wonderfully good tool and a good thing to begin with. I'm really excited to see where this might go, and that leads into my next piece of where are we going with that. Well, I said we need this. But the problem that we've been having for such a long time is that we do this every 2, 3, 4 years. It's like, you know, we finally get around, we're going to deal with some big issues here. Summit like this comes around, or conference, and people say, well, so what's our situation? I mean, what's the analysis? And then if we're lucky, we can get some funding, and then we have to sort of start that over again. Well, let's do that over again. And so traditionally in New Mexico, we've relied on studies that happened years ago. The last good gaps analysis that happened in New Mexico was in 2002, and that's when a lot of the data we've been using for quite a while. It doesn't make a lot of sense. So I'm here to tell you, as in my role, I'm going to do what I can to work with the City Council and the Budget Office with the city to see what we can do to continue this study and also to create an ongoing kind of database that will be consistently updated, and it will be funded enough to get the updates on that and coming up with a good strategy for how we're going to do that, so that not only you as providers, but people out in the community can go into this database, find out what it is they want and what's available, and go and see what's near them. What are the issues they have? We can break this down into a whole host of different kinds of needs that people have. And I think it will really help not only to map out what we have in our system, but how people can access those services. Another issue we've been working on is to identify opportunities for enhanced linkages among different components of the system. There's a lot of different examples of this that don't work. And I won't go through all of them because you know many of them, but I'll give you one example, and it's something that I can relate to because I'm part of this. Some of you know the MATS facility, Metropolitan Assessment and Treatment Services. Thank you. Over up on Zuni. It's a detox center, but it does so much more. It involves levels of assessment and people coming in that are brought there to engage in those particular services. They tend to be short-term, and then individuals are released. That's not a good word, is it? They're discharged into the community. And another program, this is one that I'm involved in, called AMCI. It's Albuquerque Metropolitan Central Intake. It does assessment, and it provides treatment vouchers to individuals that can then take those vouchers, work with those vouchers for up to a year, and get treatment in outpatient settings. But MATS and AMCI do not coordinate. They don't deal with each other. They don't collaborate on clients moving from one to the other. This is something that should be an easy, low-hanging fruit to deal with, and it hasn't been. So I'll take some responsibility for that, and I'm going to tell you now, publicly here, I'm going to do something about that and make that work. So, okay. Who's taking notes on this? Okay. Be careful on this. Excuse me, I'm struggling here. So I want to get back to that behavioral health report that came out, the study. A couple of things that came out as the high priorities, and this was done partly because in putting this information together, people were interviewed around our treatment system, providers of all stripes dealing with behavioral health. Two of the high priorities that came out of in interviewing those treatment providers were the biggest gaps were having a comprehensive crisis system and a comprehensive system of treatment. Now, those are big. When you say the word comprehensive, it's a lot to get your arms around. It's, you know, it's based on the word comprehend, so we'll see what we can do about comprehending some of that. And so let me mention some things about what we need to work on in terms of looking at a system, because that was a real formal basis of what some of our work was and what I want to talk about here. and talk about some of the progress that's been made. And I have to say that at the last summit, the last update in June, unfortunately we didn't have a lot to report on. But I'd like to say that I think we do. But they're small steps, but they're pointing in some really important directions here. I mentioned earlier the Behavioral Health Task Force that was brought together by the instigation of the City Council and members of the County Commission. And Councilor, thank you very much for being here. Councilor Ike Benton was instrumental in making that happen. The three top priorities that came out of that, the three top recommendations, and there were quite a number of them, and we're still working on those, by the way. That process is still going. It's broken out into specific action teams, similar to what this summit process is. But the three top ones that came out were Crisis Stabilization Center, supported housing for individuals with behavioral health problems, and case management services. All three of those hit the two interesting top areas that the UNM study found in terms of crisis services and a comprehensive service system. So right there's something that we're starting to get a little movement of some agreement. And it turns out that there's been a number of initiatives and task forces over the last year, and many of those recommendations continue to dovetail and they align very closely. So in many ways, it makes some of our work easier because it's pointing the direction to where we all need to go in terms of dealing with behavioral health services over the long term. And I wanted to mention a couple of things specifically about, who's my timekeeper? I'm sorry. Oh, thank you. You've been very kind. You haven't said a thing to me. 3 minutes. Oh, my goodness. So let me mention a couple of things. Supported housing and case management. We've got a system that we know that basically is anchored in two different ways. We've got hospitalization and we've got jail. And we've got hospitalization and we've got jail. And people kind of bounce back and forth. And what's happening in the middle of all of this? Where are people getting connected? And if people don't have a stable place to live, if they're precariously housed somewhere, and if they don't have some kind of case management assistance, then how are they going to maintain some level of stability and try to get their life back on track coming out of the jail or out of hospital if they're just sort of, here's the door and kind of good luck? That's not going to do it. And when I say case management, I want to be real clear. We're not talking about just hiring case managers to follow people. We're talking about a case management services, which are wraparound services. This is what we need in a comprehensive system. Have we made much progress in this? I'd like to say yes. Here's a couple of things. The City Council released some funds to provide case management services and housing for people exiting the jail, and also a pot of money for case management and housing services for homeless individuals with behavioral health problems, and they may or may not necessarily have to come out of the jail. It's at $1.25 million for both of these, $500,000 from the City Council to coordinate in a project with the county, which has put in over $1 million on a jail reentry supported housing project. Jail reentry is a terrible word, isn't it? I mean, we're not trying to help them reenter jail. We're trying to get them to sort of reenter the community. But if you say community reenter, people don't know where you're talking about. This is important. It's not an enormous amount of money compared to what we need, but it's important seed money that helps gets us started. And I'd like to say that the city and the county working together on this jail reentry project, if I can use that term, is really crucial. We've been needing to see something like this for a long time, and there's a number of people that have been working on this very diligently. And I'd like to say an area that I thought would be, one of the toughest parts with this was the courts. And the courts have turned out to be enormously open and efficient and quick to pick up on this and to make this work. This has a lot of hope for our community. We're going to start with about 75 people. We hope the vision is to move to 150 individuals with behavioral health problems that can come out into the community and receive services. I'd like to point out a couple of other things. I'm going to have to rush through here because mobile crisis services. This is high on people's lists and will be addressed in a number of different ways. I think there's some interesting plans, and it sort of coordinates with the Crisis Stabilization Center. We don't know exactly what that's going to look like. There's some good models, and I'd like to say, here's another movement, a little progress. Next week, a high-level delegation from this city at the Chamber of Commerce, who organized this, is going to Tucson to see Pima County's Crisis Response Center, and to look at that as a potential model for what we might have here in Albuquerque, and would be a kind of a center that helps people not just simply deal with crisis or near crisis, but be able to get connected to the next step, to services very directly right there, not just here's an address or here's we're going out the door. It's a crisis piece. I'd like to say a couple of other things, because I'm going to have to get off here, and I'm not moving very fast enough. I'm sorry, but there's some important things I want to say. I wanted to mention something about this 1/8 of a cent GRT, the gross receipts tax, that we had an election on in October. It doesn't have any teeth in it. There's no money in it. I'm disturbed that people around the state have heard about this and think that we already have lots of money. So we don't need any state assistance, but I'm afraid we still do. But this is important. 69% of the voters said yes to this, to behavioral health funding, to an 1/8 of a cent gross receipts tax devoted to these services. That says a lot. I think that's an important step. And I think it's important that we acknowledge that the public sees some of this. And that, by the way, was without even noting what the money would be spent for specifically. That's remarkable that people would step up and say, yeah, we need to do something about this. I think that's a good sign. Dealing with comprehensive services, let me just wind up here. We have a weak system. We have a terrible lack of infrastructure. Bernalillo County is one of the few counties in the country with a large metropolitan area that doesn't have a Department of Health. Honolulu is the other one that I know of. We have no central body, we have no central authority, central office, bureau that deals with behavioral health. We've been sort of in this fractured state for a long time, so it's not surprising that a lot of our services can end up being fractured if we don't have some kind of a body that is going to do some serious things. What are those serious things? One of them is, suppose we get the 1/8 of a cent tax. Suppose we get some big money from the Fed. Suppose a large foundation like the Kellogg Foundation, which has been funding a lot of educational initiatives here in New Mexico. Suppose they want to give us some big chunks of money. What are we going to do with that? Where does that go? How will that be dealt with? Who decides on how those we spend? Where do we have a repository for the data that we're trying to collect and the outcomes that we're trying to promote? Where is that? There's no central locus here to deal with that. Plus, we don't have any kind of a long-term strategic plan. I have to tell you, I had this nightmare a number of weeks ago where I woke up in the middle of the night thinking, we have such a fractured system now, and it's weak, and people are frustrated. What are we going to do in 5 years or 10 years when we have a lot more people? And this is a regional issue. People from the East Mountains, people from Sandoval County, from Valencia County. We have a catchment area right here that extends out to about Jemez Springs and Cochiti down to Belen, of people coming here because they don't have services. What are we going to do about that? Well, I think that we're going to do something about that. That's what I think, because I'm really optimistic about it. And because I can stand up here and say that, and there's people here that'll be listening, I hope. But we need to develop something of a long-term plan for how are we going to deal with behavioral health services in this community. We've got a lot of smart people. We've got a lot of pieces that are coming together, that are working. You know, it's time to get serious about this. We need a system, a robust system. And we've been talking about this for so many years. And it's always because the federal government hasn't done something or waiting for the state to somehow step out of their gridlock and to pay attention to us or something. And other parts of the state think we're just the Emerald City that gets everything. And they probably have a right to, considering that they have so little. But we have a lot to do here, and I think there's a lot that's happening. We have initiatives, we have people talking, we've got some new money and some real serious ideas about how we're going to move forward. And so I would like to say that we're responding to opioid abuse and treatment in a way that has to fit into this. It has to fit into this level of a system. And we have a lot here that's moving along. And I'm confident. Well, maybe that's too strong a word, maybe because I've got a cold, but I'm feeling pretty good. So thank you all very much, and I'm going to pass this along.
Good afternoon. I'll see if I can catch us up on some time here. I am both blessed and cursed to come so late in the afternoon after so many amazing academics, speakers, passionate individuals who have a lot of statistics and data to share with you. I do not come with any of that for my message for you this afternoon. I am an evaluator, so I could have downloaded a lot of data on you, but I chose not to. I want to first start with thanking Marcia and Drs. Bill and Harris Silver, well, Bill Weiss and Harris Silver, for putting this effort together. For the last 2 years, I've been involved with some amazing conversations with a diverse group of professionals that I've watched the three of them try to herd cats, and they've done an amazing job, and we should all be grateful for their efforts. I know I am. I'd also like to thank each and every one of you sitting in the audience today. It's clear this is an issue that we all care about and we all want to see resolved. So as I said, no data. I come to you with a message today. I'm going to move this before I throw it off the stand. I come to you with a message today. Together, we are making progress. Most of us know or has heard of someone who is in recovery from an opiate addiction and lives to tell their story. Collectively, the stories they tell are of people who are complex, have a great amount of strengths, and whose identities are not mutually exclusive. Their stories teach us about addictions, poverty, joblessness, lack of education, co-occurring and sometimes triply occurring diagnoses, and even of care that wasn't available to them just for these reasons. These stories also tell us of recovery and resiliency. So as Bill mentioned earlier, I am a native New Mexican. I was born in Las Vegas, New Mexico. I have seen firsthand the tragedies, the drama, the way that this epidemic tears apart our communities. I've witnessed the incarceration, the sickness, the illness. I'm also very privileged to say that as someone who's worked with Albuquerque Healthcare for the Homeless for 9 years now, my bio's a little outdated, and I have seen over the past 7 years, we've been running a medication-assisted treatment program for people who are homeless, recently released from incarceration, and addicted to opiates. I saw, talked to, interviewed, and connected with people who have recovered. They have done amazing things with their lives because we gave them the treatment that they needed, when they needed it, and in the way that they sought it. Now that I've shared that with you, I would also like to tell you that this is not about me. And I would also venture to say that today, right here, right now, in this room, this is not even about people experiencing an addiction. This conversation today is about you and I, about what we can do to make a difference in this epidemic. Not what people living with an addiction can or cannot do, but what we can do. So we've been brought together, thanks again to the amazing people to my right over here, to have these tough conversations, to exchange information about our successes and our failures, to inquire about the right service for the right person at the right time. This is our discussion, and the focus must be on us, must be on what we can do. We must take this opportunity to figure out the ways that we can meet the standards of care and become even more sophisticated over time. And everyone in this group has the power to do that. Together, we are making progress. So clearly, part of my theme is progress. I was also supposed to come up here and talk about challenges. Some of the things we're talking about today are long-term solutions. The data is not yet available. And some of the progress are still challenges. And some of the challenges also have demonstrated great progress. So I will be talking about, I want to point out quickly, in your packets for those of you who just got in or forgot from the reminder this morning, are one-sheeters that Dr. Harris Silver put together, very detailed about some of the progress we have made since Summit number 1. So I will not follow the sheet, but I think I've covered most of them. But if I miss any, please check those out. They will tell you about some of the specifics of the work we got done. So through these discussions and challenges and sometimes very heated conversations, to say the least, we've discovered and discussed how prescription, any kind of medicated-assisted treatment must be medicated-assisted prescription must be tied to treatment. As Mike talked with you about earlier, the treatment cannot be fragmented. It must be comprehensive, it must be quality, and it must be effective. When I talk about quality care, I'm talking about comprehensive, accessible, and integrated care. When I talk about effective treatment, I'm talking about measurable treatment that we can say to anyone who asks us at any time who got better and how. We need to commit to immediate screening and treatment for people when they show up at our shops. We cannot wait. We need to be ready to address their needs for as long as they need it. Each publicly funded practice, clinic, or healthcare center can stand up and commit to training and mentoring providers that are eligible through the Project ECHO program and to get licensed to treat people. That would be, if we did that, that would be 30 at a maximum for a newly licensed provider. And I'm sorry if I'm using the wrong terminology here, but newly licensed provider. We could expand access to medicated-assisted treatment very rapidly. Low-hanging fruit. We need to make funding available for detox, including alcohol. We have to have a continuum of care, as pointed out in the one-sheeter Harris put together, that includes non-opioid-based alternatives in our continuum of care. In fact, Paul Tucker of the Turning Point Recovery Center, who was brought to this table by our amazing, fearless leaders, who can start training this year, anytime. He's ready, he's waiting. We can integrate with other professionals. If you're a primary care provider, get to know your behavioral health care providers in your community. If you're a behavioral health provider, get to know your primary care providers. And I will take a moment to gratuitously do a shout out to get to know your community health centers. They have recently been lucky to have some infused resources to hire expanded behavioral health providers and medical staff. Get to know them, partner with them, work with them. We have to learn to listen to what the patient tells us. We have to let go of what we believe is right or wrong, what we believe to be the best course of treatment. We have to listen to what the patient tells us and get to know their community's cultural context and be more culturally humble. Some of the more challenges that have had some progresses include that we must address the social determinants of health. In Mike's presentation, that includes wraparound social support services. Again, connect with your community health centers. They have services available and can help you with some of these challenges. We know that we have to address these social determinants of health. If someone is living without a home and you're trying to treat their opiate addictions, they are compounded in what they're supposed to pay attention first. If they don't have a job, if there's no employment available to them, how are they supposed to sustain themselves? We must address all of these issues, and we can. To our funding and tie our funding and investment models to best practices. You've heard that over and over and over again today, and I'm going to say it again. Our funding must be tied to best practices. We should not have to choose between a behavioral health provider or a primary care provider in one visit. We know, you've also heard this more than once today, that people need the care in one visit, as much care as you can possibly give them. Now, I will tell the funders and investors that that needs to happen, but I will also remind us that with that comes a lot of responsibility. We have to know we're giving the right treatment to the right person at the right time. Our governing bodies of health centers and Centennial Care can encourage and even require licensure as part of the credentialing process. We need to eliminate the disconnect between addiction treatment centers that do not take Medicaid and people who take Medicaid and do not provide addiction treatment. Last but not least, and Harris is going to talk about this, we have our behavioral health parity law that we need to take advantage of, make our policy and our models work for us. That is a great progress that we can pull from to make this work. What's my time? 5 minutes? A little over 5. I want to do a quick activity. It was a lot longer and there was a lot more steps to it because I wanted to make a visual point, but I'm going to keep it short. We have to keep things moving. I would like everybody in this room who has ever known someone who has died from an untreated opiate addiction, to please stand up. If you have known someone who has died from an untreated opiate addiction, please stand up. You will notice I also stand, and I also have experienced that. I want you to just take 1 second, look around this room. This is the work we have left to do. This is why we come together. You may sit down now, thank you. This is why we come together to do this work, because even one person who dies from an untreated opiate addiction is too many, with the knowledge, skill, resources, and amazing passion that is in this room. Not one is too many. So, in case you forgot, I leave you with this final message. Together, we are making progress. Most of us knows or has known someone who is living in recovery from an opiate addiction who lives to tell their story. Collectively, these stories they tell are of people who are complex, full of strengths, and whose identities are not mutually exclusive. Their stories teach us about addiction, poverty, lack of education, joblessness, homelessness, and even care that was simply unavailable to them for these reasons. These stories also tell us of resiliency and recovery. Together, we have the collective knowledge and power and determination to expand medicated-assisted treatment in this county. Our efforts matter, and I hope that you will leave today's summit with an increased or renewed commitment to your role in this work. I will also point out, I'm so glad this was in there, they have put in your packet a sheet where you can jot down what you commit to do when you leave today, whether it's working on more summit initiatives or going back to your own office, clinic, health center, and making a difference today. Thank you for your time.